Hello, everybody. We're going to get started. I have the pleasure of announcing and introducing Dr. Nancy Albert. Nancy really doesn't need any introduction. You guys all know her, which is why this room is packed. As you know, Nancy's a past president, but she's also the Associate Chief Nursing Officer of Nursing Research and Innovation for the Cleveland Clinic Health System. She's a clinical nurse specialist in the Heart and Vascular Institute of the Kaufman Center for Heart Failure at the Cleveland Clinic in Cleveland, Ohio. Nancy works as a nurse leader, nurse scientist, advanced practice nurse in an ambulatory heart failure clinic, consultant, and educator. She has over 240 peer-reviewed publications in medical and nursing journals, over 15 book chapters, and she's the editor of 2016 book titled Building and Sustaining a Hospital-Based Nursing Research Program. When do you sleep? Jeez, that's crazy. She's also past president of the American Association of Heart Failure Nurses, so it gives me great pleasure to welcome Nancy for this talk.
Thank you, Lisa. You're so funny. Well, I'm thrilled to be here. I don't think I need to stand next to the podium. I'm mic'd up. Okay, so we're going to talk about the 2016 ACC, American College of Cardiology, American Heart Association, and Heart Failure Society of America Heart Failure Guideline Update. What a mouthful, huh? So just to let you know, I do have two disclosures. I'm a consultant for Novartis, and I'm on the speaker bureau for Amgen. And interestingly, those are the two companies whose drugs are featured in the update. So just as a disclosure. These guideline updates were just released on May 20th, so you have seen them as an EPUB ahead of print. We're still waiting for the official print copy. And they focus on pharmacologic treatment for heart failure and reduced ejection fraction, not preserved, only reduced ejection fraction, stage C. So patients that previously had symptoms or currently have symptoms and now are labeled clinical heart failure. And they focus on two themes, the renin angiotensin aldosterone system and Ivabradine, which is a drug that we're going to talk about. So in the renin angiotensin aldosterone system, they talk a little bit about ACE inhibitors and angiotensin II receptor blockers. And the main focus, or what's really new, is a new class of agent called an angiotensin receptor Neprilysin Inhibitor, which I know you've been hearing about a lot of this meeting. But hopefully my background that I'll give you will really help give you a shape of why these drugs made it to the guidelines, and that's my goal for us today. So I'm going to start out by just showing a few brief slides about ACE inhibitors and ARBs and put it in perspective with the newer drug, and then I'm going to show you the actual guideline recommendations. So this is a nice slide that shows a pooled analysis of 32 randomized controlled trials for ACE inhibitors. So keep in mind that we all know, this is old news to us, that ACE inhibitors can reduce total mortality, reduce mortality due to heart failure, and reduce death or hospitalization due to heart failure. So right, no surprise to anybody there. If we look at this study, this meta-analysis over here, this is of 5 trials, and you can see the trials going across the top over there. And what I really wanted you to notice was the risk reduction for mortality, and this is all-cause mortality. So when you put the 5 trials together, there's about a 20% relative risk reduction for all-cause mortality. So keep that in mind, because when I go and talk about the ARNI, the new drug class, it's comparing a new drug class to an ACE inhibitor, not to a placebo. So you need to keep in mind what the benefit was with the ACE inhibitor before we get to the next phase and talk about the ARNI. Now, again, when we think about treatment of every 100 patients could prevent about 7 major events. The major events are combined as death, C-HF emissions, and in this meta-analysis, a future myocardial infarction. So we do know that ACE inhibitors are important for us in our patients with heart failure. Now, what about angiotensin receptor blockers? Well, the first thing you're going to notice if you see on this slide here, if you look over here, this is years, and this is outcomes. And again, this is a nice Kaplan-Meier curve. And what I really want you to do is notice the hazard ratio, or the risk. And when we look at these, if you're not used to looking at these kind of curves or statistics, you take the number 1.0 and subtract this number, and you'll see the risk reduction. So you can see that in the CHARM alternative study, there was about a 12% risk reduction. Not quite as good as the ACE inhibitors. Remember that those 5 studies together gave us a 20% risk reduction. If you look at VALHEFT, which was a study of patients after myocardial infarction, there was about a 13% risk reduction. So for those of you who've always wondered why in the guidelines they always talk about using ACE inhibitors first and only using an angiotensin receptor blocker in patients who have a cough or angioedema or some contraindication, does this make sense now why we have one that gets a little bit more bonus than the other? So when you look at mortality overall for patients with heart failure and reduced ejection fraction, we all know that we give 3 classes of drugs together, either an ACE inhibitor or an angiotensin 2 receptor blocker, and a beta blocker, and a mineralocorticoid receptor antagonist, assuming that our patients can tolerate the threesome group of drugs together. And that, of course, is not accounting for aspirin and diuretics and the other 15 drugs your patients are on, right? And we know that we'll see a decrease in mortality if we put these drugs together. Now, I want you to notice in this one, for the ACE inhibitor, it doesn't have a 20%, it only shows 16%, and that's because it was based on the SOLVED studies, SOLVED prevention and SOLVED treatment. The SOLVED studies were the largest ACE inhibitor trials, and so that's why it used those. If you just look at the SOLVED treatment group, not the prevention group, but the treatment group, the risk reduction was about 18%. So just a hair lower than the 20% you saw in the big meta-analysis of 5 studies. Now, we like to think that that's great, right? We've got this nice benefit in terms of mortality, but we all know that if you've been a nurse for 5 years or 10 years or 20 or 30 or maybe more, that for the longest time we've had this little saying that in heart failure, once you're diagnosed, you've got about a 5-year, 50% mortality or survival if you're looking at the glass half full, right? And we haven't really done a very good job of improving outcomes. So when I'm talking about these drugs coming up and why the guidelines made the changes, keep in mind that these are drugs that are actually now showing us some benefit that we didn't see previously. Now, I'm going to just veer off for the next 3 slides and talk about guidelines. You know, the whole reason why we have guidelines is for us to figure out, A, what the best evidence is based on this consensus panel of experts who are making these decisions for us, and then for us to apply it in clinical practice. It does no good if we don't apply the knowledge we have. And this is a great study. This is a little bit old now, from 2005, but the message is still really important. And what you see here, if you look at the red bars, is the level of risk. And red is high risk, green is low risk, and blue is moderate risk. And if you look at a hospital discharge over here for ACE inhibitor, ACE or ARB, or beta blocker, what you see is the patients at greatest risk for mortality are least likely to get the drug. Least likely. So we're not even giving the evidence-based therapies to the right people. And some patients or some physicians or healthcare providers will say, well, I didn't order it at discharge because, you know, they're still unstable, but I'm going to give it in the outpatient department when they come back to see me. But when you look at 90-day follow-up, do you see much difference? Nothing. I mean, maybe a hair higher, right? But I mean, we're talking splitting hairs here. So if we miss our magical moment while the patient's in the hospital and we wait till after discharge, we may be missing the moment altogether. And again, if you look over here, it's the patients in red and in blue, the moderate and high-risk patients that get into the most trouble. They need these drugs the most, and yet they're the least likely to get them. So when I get on my high horse here about guideline recommendations, I'd like to say there's 2 issues we need to face over here. And as nurses, these issues are just as important to us as they are to our medical healthcare colleagues. 1, medications don't work in patients who don't take them. Right? So what does that mean for us as nurses? We need to think about how we can understand the guidelines ourselves, really understand them so we could talk the talk with our physicians and with our patients, and then also how we can advocate for patients and actually step it up so patients are getting the right drugs. And then 2, healthcare providers who fail to order and who underdose heart failure medications are really not serving their patients' best interests. And oftentimes we are afraid to to step it up. And so we need to figure out how we can be assertive when we need to be assertive and not have this constant fear. You learn by your mistakes, yes, and of course we want to be ethical and give our patients the best care possible, but we know these drugs work. We know that there's a lot of sub-analyses for a lot of these drugs that tell us what to do, and yet we still make excuses why we're not using them. So we need to get past the excuses and step it up. Now, the reason why I'm having this little digression here before I jump it back into the guidelines is because if you look at any papers out there that look at the time of FDA approval or the time of guideline recommendation, and then you look at how long it takes to get the majority of patients on the drug, do you guys know what the average amount of years is? Not months, years? 10's too low? 17 years. It takes 17 years to get it. So again, you can see over here 1995 to 2004, so it's 10 years, and it took 10 years to get RAS inhibitors up above the 50% mark. Now, of course, it's 2000. By about 2013, we got to 80%, and by 2015, we got to 90%. But why is it taking so long? So I don't want to see this length to stick around for these new drugs. So hopefully you're going to be learning some new things coming up, and you'll be able to apply some of these lessons. So how does an ARNI, an angiotensin receptor neprilysin inhibitor, fit into heart failure REF treatment? Well, the first thing we need to remember is that this is a combo drug. It's a polypill. It's 2 drugs in 1 pill. And because of that, for those of you who see the 2 drug dosings and think it's confusing, all polypills have separate drug dosings. You never see hydrochlorothiazide and lisinopril with 1 drug dose. It's 2. So for those of you like me who've used polypills in the past, you just have to get used to seeing 2 different drug doses. So just get over it. This is a polypill, right? All right. So I hear this question all the time. Why isn't 1 drug dose? Well, it's a polypill. You can't make 1 drug dose, or our FDA will not allow that. So let's talk about the neprilysin inhibitor first, because most of you already know what an angiotensin II receptor blocker is. So a neprilysin is a substance, it's a peptide that degrades many endogenous vasoactive peptides. Now, what are the endogenous vasoactive peptides we're talking about here? Well, we're talking about atrial natriuretic peptide, B-type or brain natriuretic peptide, whatever term you like best, C-type natriuretic peptide, which is formed in vascular smooth muscles, adrenomedulin, bradykinin, substance P, calcitonin gene-related peptide. These are all vasoactive peptides that vasodilate. Now, they do have other roles as well, and I'll show you those on the next slide. And they have a short half-life in your bloodstream. And the reason why they have a short half-life in your bloodstream is there's this little substance that comes along called neprilysin, and it degrades these good vasoactive peptides. So these vasodilate, neprilysin comes along, and it degrades them, and it turns them inactive. So here are the peptides we just talked about, and how do they act? What do they do in your body? Well, they decrease neurohormonal activation, especially renin angiotensin system activation. They decrease vascular tone, so they vasodilate, right? They relax blood vessels. They decrease cardiac hypertrophy and fibrosis, and they decrease sodium retention. They do that by mild diuresis and mild natriuresis. So you lose a little bit of water and you lose sodium with these drugs. So these are good vasoactive peptides, right? Would you all agree? This is all good. And neprilysin comes along and degrades it. Bad, 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 right? And so now we have a new drug called a neprilysin inhibitor that prevents the degradation and keeps these substances in your bloodstream longer. So you've got more good lasting in the bloodstream longer. Everybody with me? Yes? Okay. So now let's talk about the renin-angiotensin-aldosterone system. You probably all remember from Pathophysiology 101 that angiotensin 1, in the presence of an angiotensin-converting enzyme, converts angiotensin 1 to angiotensin 2. And angiotensin 2, when it gets in your bloodstream, looks for the angiotensin 1 receptors in your endothelium, and attaches and causes all the lovely effects you see on the side over here. It causes vasoconstriction, it causes sodium retention, volume expansion, vascular smooth muscle cell growth, which is another way of saying it causes the heart to get bigger. We already said vasoconstriction, left ventricular dysfunction, and more fibrosis and hypertrophy. In addition, the renin-angiotensin system, once it's turned on, stimulates your adrenal gland to produce aldosterone, and that accentuates everything you see over here. Well, what you may not know is neprilysin also degrades angiotensin II. Ooh, so now we have neprilysin degrading the stuff we don't want to be degraded, right? And we have angiotensin II, or neprilysin, degrading the bad stuff that we don't like anyway. But if we're going to give somebody a neprilysin inhibitor, it's going to prevent the degradation of angiotensin II in the bloodstream. So when we're giving this medicine, it's got to be a polypill, because we need to have the neprilysin inhibitor to cause the good effects on the vasodilation side of life, and we need to do something like give valsartan to prevent angiotensin II from attaching to all those receptors, because there's more in the bloodstream from the neprilysin inhibitor. Does that make sense? So that's why it's a polypill. So if you look at this picture here, it kind of puts it together. You have myocardial or vascular stress or injury. It's going to cause an increase in activity or response to maladaptive mechanisms. What I mean by that is sympathetic nervous system release and renin-angiotensin-aldosterone system stimulation. It's going to decrease the activity or response to adaptive mechanisms like your vasodilators out there, like, let's say atrial natriuretic peptide and B-type natriuretic peptide, right? And that's going to cause evolution and progression of heart failure. So if I give a drug that's a polypill that includes angiotensin receptor blocker and neprilysin inhibitor, I prevent the evolution and progression of heart failure. So hence we have our new drug. It started off with called LCZ6966. So if you look in all the research trials, they use the cute little numbers over here. But again, this is a combination of valsartan, an angiotensin II receptor blocker, and sacubitril, which is a neprilysin inhibitor. And it's the combination of the two given together that leads to the benefit. You could give valsartan by itself, right, and just inhibit angiotensin II, but you can't just give neprilysin inhibitor by itself, because it's going to cause too much circulating angiotensin II. All right, so the Paradigm Heart Failure trial was a great trial. First of all, it was one of the largest trials we've had in reduced ejection fraction, and it didn't compare a new drug to a placebo, it compared a new drug to standard of therapy. So that really helped us get a really good sense of how well this drug is really going to work for all of us in terms of giving it in clinical practical scenarios. And it was meant to replace an ACE inhibitor or an angiotensin receptor blocker in patients who are still on the other evidence-based guideline recommended therapies. So you can see over here the entry criteria for Paradigm. You had to be functional class 2 through 4 heart failure. Your ejection fraction, they initially started out with an EF of 40%, and then over time, about a third of the way in, they decreased it to to 35% or less. You had to have a little bit of an elevated BNP greater than 150, or it could be a little lower if you had been hospitalized within the last 12 months. You had to be able to have history of tolerating an ACE inhibitor and ARB and being able to use it. You had to be on guideline-recommended beta blocker and mineralocorticoid receptor antagonist, and you had to have a systolic blood pressure of 95 or greater, an estimated glomerular filtration rate showing mild to moderate renal dysfunction but not severe renal dysfunction, and a potassium cutoff of 5.4 or less. Patients who were not entered were people who had a history of angioedema related to previous ACE inhibitor or ARB therapy. Now, the reason why they made this rule is because we learned a lot from a little drug called omopatrilat many years ago. That was a combination of a NEP inhibitor with an ACE inhibitor, and the combination still caused too much angioedema. So they were very cautious in this study to make sure we would not get into that trouble. Patients taking an ACE inhibitor concurrently, so if you couldn't stop the ACE inhibitor or the patient refused to stop the ACE inhibitor, you couldn't be in the trial. The same with aliskiren, which is a direct renin inhibitor. Again, too much renin-angiotensin-aldosterone system blockade going on at once. You were only on one. This is a replacement, not in addition to. And again, patients were excluded if they were currently in an acute decompensated heart failure state. And that's an important thing for us to remember, because oftentimes when we start taking up and using new drugs, we forget the rules about how they were studied. And this drug was not meant to be used during an acute decompensation when patients are fluid overloaded and maybe had some low blood pressure going on and all the other problems you see during the midst of an acute decompensation. And again, for the research study, if you had severe pulmonary disease, you were also contraindicated. I'm not going to go into great detail with this slide, just want to remind us all that this was a two-phase study. There was a single blind run-in period that lasted 6 to 8 weeks, and then there was a double-blind period where patients were randomized in a one-on-one fashion to either to get the sacubitril/valsartan combination or to get enalapril. And you'll notice the enalapril is at what we would call target dose, 10 milligrams twice a day or 20 milligrams a day. So again, and the 20 milligrams twice a day of the new drug is what is now the target dose for this drug as well. So how well did this study do? Well, here you could see enalapril, and you'll notice how big the sample arm is, over 4,000 patients, and here you see LCZ 696. What we see here is a hazard ratio or a risk reduction of 20%. And look at all the p-values. Usually you see less than 0.001. I thought you'd be curious to see all the p's there. It takes 21 people to be on the drug for a year, the number needed to treat to save a life. So not that many people need to be on this drug to save lives. So this is an important drug. And remember, we were comparing it to standard of care, not to placebo. So you got to keep this in the back of your mind. Now, again, I should go back here. This was the primary outcome of cardiovascular death and time to first heart failure hospitalization. So primary outcome, cardiovascular death, time to first heart failure hospitalization. When they just looked at cardiovascular death by itself, again, the sacubitril/valsartan arm did much better. And again, the risk reduction was 20%. The relative risk reduction. And again, lots of zeros in that p-value, and the number needed to treat was 32 to save one life and prevent this cardiovascular death. And if you look at the bottom over here, I added in the hospitalization for heart failure. The relative risk reduction here, the hazard ratio here was 0.79, meaning that there was a 21% reduction in hospitalization. So for all of you trying to help your patients with hospitalization issues, again, not only does it keep patients alive longer, but it also helped with hospitalization to a great extent. Now, I don't expect you to be able to see the slide here, but there is something I do want you to see. This is what we call a forest plot, and you can actually see two forest plots here and a bunch of little themes. And this little line right here is called the line of unity. This is the number 1. Everything on this side of the line of unity means that the sacubitril/valsartan was better. Everything on this side of the line of 1 means that enalapril was better. The same over here. This side, sacubitril/valsartan better. This side of this line of 1, the other drug better. And what you could see here is for every single sub-analysis they did, guess what won? The sacubitril/valsartan. So there were some scenarios where there was no difference between groups, but everything trended to go in the right direction. And then for many of these, it was statistically significantly better to be on the sacubitril/valsartan rather than being on enalapril, a typical ACE inhibitor, our therapy of record for patients with heart failure and reduced ejection fraction. They also looked at all-cause mortality, and I always wonder why we are expecting patients to do better from an all-cause scenario. Patients die from all kinds of things, but even in this study, they did better. And you could see here there was a 16% risk reduction for all-cause mortality. We believe some of that was due to sudden cardiac death. Whatever the properties are in this drug, it actually helped to reduce sudden cardiac death. So again, very helpful. Now, what made it even more helpful with the Guideline Committee was developing the guidelines is if we look at the adverse event profile, there's only one adverse event that happened more often in the sacubitril/valsartan arm, and that was symptomatic hypotension, which shouldn't be a big surprise to any of us because, hey, we're giving 2 vasodilators, and in enalapril, we're only giving 1 vasodilator. So we're increasing our risk for vasodilatation and symptomatic hypotension. So you could see the 588 versus 388, and that was statistically significant. But if you look at the other outcomes, serum potassium greater than 6, serum creatinine greater than 2.5, there was statistical significance, but it was the enalapril arm that did worse. The sacubitril/valsartan group did better. Cough, much less in the sacubitril/valsartan arm. If you look for discontinuation for any adverse event, again, it was statistically different between groups, but it was because there was less renal impairment in the sacubitril/valsartan arm. A big problem for a lot of our patients, and yet there was less of it. So that's a good thing. And if you look at angioedema, there was no difference between groups. There was no airway compromise in any patient, whether they were on enalapril or the sacubitril/valsartan. And you could see the number of people out of 8,400 people in the study was 4 people were hospitalized. So a very, very, very small amount of people who got into trouble with angioedema. Now, I often get asked the question, well, what about age? You know, the mean age of this study was in the 60s, and my patients are 75 and 80. So I thought I would just show you some sub-analyses that maybe you haven't seen from company-sponsored studies or drug presentations. And again, if we look over here, this is the line of unity, so a different way to look at a forest plot, and this is the mean. And you could see for age 20 all the way up to about age 90, patients did better in the valsartan sacubitril arm versus the Entresto arm. So if the green line goes above the line of unity, that means enalapril did better. And this was for cardiovascular death and heart failure hospitalization combined endpoint. Over here, if we just look at heart failure hospitalization, the mean was below the line of unity at all age points. So even though there were very few, the reason why the confidence intervals are so wide, that's what the gray is because very few people were in their 20s, and so the confidence intervals are wide. But in general, this drug did well across all age groups. The other thing that we could show you is what happens with quality of life. So we like to look at quality of life. Now, this is the Kansas City Cardiomyopathy Questionnaire, and a higher number is a better number. So if we have a deterioration, that's a drop. And we like to say that there's a clinically significant difference in KCCQ when we see a 5-point change. So a 5-point drop means worse status. And what you could see over here is regardless of the patient age, so let's look down here, less than 55, you could see the different age groups over here all the way up to greater than 75. The enalapril arm were more likely to have a greater deterioration than the sacubitril/valsartan arm. So again, from a quality of life perspective, patients were telling us, self-reporting, that they felt better in the sacubitril/valsartan side versus the enalapril side. And if we finally look at these two Kaplan-Meier curves here, I'm going to make a little bar go up here so you can see. So this first one I'm showing you is age 55 years. So now the curve starts at age 55 and goes across. And what I want you to do over here is see the difference in terms of survival times. So from age 55 and over, when they did the analysis, patients in the sacubitril/valsartan arm had a 2.1-year increase in time being alive. Now, for a lot of our patients out there, 2.1 years, you could see a lot of life events go on. Marriages, cruises, whatever it is to make you happy. So that's really important. If you look at the other side, now we're seeing age 65 and greater. So if you look over here, now the curve starts at age 65, and you could see the separation better when you're getting into the older years. And if you look over here, again, we could see there was a 1.6-year difference in survival time. So again, no matter how they cut the dice, from an age standpoint, patients who were older did just as well as patients who were younger and got that benefit. So keep that in mind. Now, I often get asked the question, well, what about patients who can't be on the target dose? What if we have to reduce the doses? There's still benefit. So over here, you could see that about 42% of patients had to have their dose reduced in paradigm heart failure out of the 8,000 patients. This includes 42.5% in the enalapril arm, and sacubitril arm had 41.9%, so very similar. Would you agree? And those who needed a dose reduction had more severe heart failure at baseline. And these were the factors that turned out to be associated with needing to reduce the dose. So they were older, they were more likely to have ischemic cardiomyopathy, more diabetes, higher end-terminal proBNP, more likely to be functional class 3. There were very few patients in functional class 4, so they weren't able to really assess that as well. Less use of beta blocker and mineralocorticoid receptor antagonists. I hope that means it was because they were too sick to be on them for some reason. Higher creatinine, lower systolic blood pressure, higher diuretic, and higher use of CRT and ICD. All of these factors do portend to a picture telling us that the patient was probably a sicker patient. So what happened with the reduction in dose? They looked at the analyses in two ways. The first way they looked at the analysis was what happened when they censored at the dose reduction. And interestingly, they still found, in terms of the primary outcome, remember the primary outcome overall was a 20% risk reduction in cardiovascular death and in heart failure hospitalization. Now you see a 21% risk reduction. So even when they had to censor the analysis, when they decreased the dose, the patients still did well. And when they looked out toward the end and looked at these patients with the lower dose throughout the whole life of the study, again, 20% risk reduction. Down on the bottom over here, I'm showing you the different doses of the sacubitril/valsartan, even at the lowest dose, which was less than 100 milligrams, enalapril at its lowest dose, and I want you to see the risk reduction is still what is that, 24%. So patients the relative risk reduction did well whether they were on the lowest dose, a moderate dose, or on the target dose. So over here you can see the patients who were on the target dose, a moderate dose, and the lowest dose, and the relative risk reduction. So patients on the sacubitril/valsartan group did better regardless of what dose they were on. So when we look at the summary of all findings, you could see that again, at the time, LCZ696 did a better job of reducing cardiovascular death, heart failure hospitalization. They did a better job of improving symptoms and patients having improved quality of life. And the adverse event profile was really very reasonable. We have to worry about symptomatic hypotension, but for all the other things we typically worry about, we did better than being on an ACE inhibitor. And this is probably the crux of the matter here. So if we are to compare an ACE inhibitor, and again, I'm using the 18% of the SOLVE treatment trial, looking at angiotensin receptor blocker, and this is very generous using 15% because you saw in some cases it was more like 12 or 13%. And you could see what the angiotensin receptor neprilysin inhibitor is giving us on top of the ACE inhibitor. So you can see this huge benefit we're getting that we're not getting with enalapril alone. So with that as background, now we get to what the actual writing group from the guidelines had to say. And what the writing group had to say is, well, first let me explain for those of you that are not good at understanding the writing group's recommendations. COR stands for class of recommendation, and that's what I like to call the strength of recommendation. The strength of recommendation is based on how strong of a research study was done. A randomized controlled, double-blind, placebo study has got the strongest strength. So it's a level 1 strength, and that means it's recommended, it's strong and strong data. And then they give level of evidence. Level of evidence is looking at the quality of our studies. They looked at, is it randomized or is it non-randomized? Is it a strongly developed study? Is the methodology strong? Are there a lot of limitations to the research? And for ACE inhibitors and angiotensin II receptor blockers, the level of evidence is an A because there's so many studies out there on these topics. For the new ARNI, we've got the Paradigm heart failure study and a lot of sub-analyses from the Paradigm. But really, we have this one major study. So it got a level B, which means moderate quality, and the R stands for that it was randomized evidence. So that's what that means. And so if you read the recommendation, they are now recommending that we can inhibit the renin-angiotensin system with an ACE inhibitor or an angiotensin receptor blocker or an ARNI in conjunction with an evidence-based beta blocker and an aldosterone antagonist in patients who meet the criteria for these drugs. So they're pretty much saying you could use any of the 3 drugs, but they go on to say for ACE inhibitors, they're beneficial in patients with prior or current symptoms to reduce morbidity and mortality. For ARB, they're saying, really, we ought to save these drugs for patients who have current symptoms who are intolerant to ACE inhibitors because of cough or angioedema. So don't use these first, is kind of what they're saying here. And then look at what they're now saying for our new ARNI group. In patients with chronic symptomatic heart failure REF and New York Heart Association functional class 2 and 3 who tolerate an ACE inhibitor or an angiotensin receptor blocker, if you're still symptomatic, if you're functional class 2 or 3 and you're already on the other drug, hello, we need to switch you to this drug because do you remember the benefit in terms of the risk reduction, in terms of improvement in outcomes? So the new guidelines are suggesting that we switch our patients to this new drug because it may, in the end, improve survival. And I know I don't have time to show you a lot of data, but this drug did better even in stable patients, or what we call stable patients, functional class 2 patients. So it wasn't just the severe patients who got better, what we would typically call stable patients also did better. Now, there are 2 recommendations that get a red class of recommendation. Red means is harmful, and so we do need to pay attention to that. The first one is that an ARNI should not be administered concomitantly with an ACE inhibitor or within 36 hours of the last dose of an ACE inhibitor. What does that mean for us as nurses? I think what it means for us as nurses is if you're a prescriber or if you're a nurse working with your healthcare providers who are prescribers, we need to ask the patient to bring their bottles with them into the clinic if they're an outpatient. And we need to put a big red X on the bottle that's the ACE inhibitor or the ARB, because patients oftentimes say, well, I just got this refilled. I need to give it. I need to take it. And they may not realize the harm they could be causing themselves by putting the 2 together. The harm is angioedema, and that is the #1 reason why we don't want to use the 2 together and why we want to wait the 36 hours and give that washout period. And ARNI should not be administered in patients with a history of angioedema. So if you had them on an ACE inhibitor, they got angioedema, you switched them to an ARB and they did great, no, you still cannot use this drug. You got to just keep them on the ARB that they're on. So don't start the angiotensin receptor neprilysin inhibitor. All right, so that's it for that part of the guideline. I'm going to quickly go through the next guidelines so we can finish here. This first slide is just a nice overview slide to remind us that heart rate is an important factor for us in terms of death or heart failure hospitalizations. We know that patients who have a heart rate greater than 70 beats per minute are at greater risk for worse clinical outcomes. We've known this for a long time. The first time I really paid attention to it was when I was doing heart rate variability analyses back in the mid-90s when I first really delved into heart failure as my role and started reading up on fast heart rates. At one time, we thought 100 was as fast, it had to be 100 as a cutoff, and then the next paper showed 87, and then the next paper showed 77, and now we know even a heart rate of 70, a resting heart rate. So these are people who are relaxing, sitting in the chair watching TV. A resting heart rate greater than 70 is harmful to our patients with heart failure. And just for the sake of the slide, I want you to notice that if your heart rate is greater than 87 beats per minute, you have close to a 50% mortality in as little as 30 months. We're not even talking 3 whole years here. So keep that in mind because I'm going to show you another slide with the effect of Ivabradine after this. So you can see at the bottom, there's an increased risk of, if you go up 1 beat per minute, you increase your risk of mortality by 2.9%. And if you go up 5 beats a minute, you increase your risk of mortality by about 15.6%. So why is heart failure a bad actor? Well, heart failure speeds up your heart rate. You need more oxygen, right? So you've got increased oxygen demand. You may not have increased your supply because you've got heart failure and you've got stuff going on. And so now in the short term, it's going to decrease left ventricular function and increase heart failure. In the long term, it's going to increase death. So we've got this, this is a picture of a sinoatrial node, and if you look inside of a sinoatrial node, we all know that we have electrical conduction and mechanical conduction, right? And when electrical conduction happens, depolarization occurs because the inside of the cell goes from a negative amount of amperage up to a positive. And as we go from negative to positive, we get electrical conduction that leads to mechanical contraction, right? And there's a lot of different channels that are inside or around the sinoatrial node. So you could see over here calcium and different areas, beta receptors that all attach to the sinoatrial node and can affect influx and outgoing of electrolytes that affect the charge more negative or more positive. One of the little channels that you see over here that I put in blue is called the IF channel. That is what we like to call the funny channel. It really is called the HCN channel, which has got a really long word. It's hyperrepolarizing, activated, cyclic nucleotide gated channel. So because it's such a long-term HCN channel, we call it the funny channel for short, okay? So I didn't come up with the funny channel, somebody else came up with that. But this is the channel that we now know allows for early depolarization. So let me show you what I mean by that. So if we were to stick a probe inside of our sinoatrial node, so up here's our sinoatrial node, we stick a probe inside and now we could see the milliamps of electrical current going on inside the sinoatrial node. Everybody knows that depolarization or repolarization is right over here. Depolarization is this upstroke. This is active depolarization. And then we also have this period of what we call diastolic depolarization. This is when the sodium starts creeping into the cell, making it more positive, and when it gets positive charged enough, then we get active depolarization, and the electrical current goes throughout the SA node and out the door to the rest of the atrium and down the junctional fibers, et cetera. So what happens with Ivabradine? How does it work? Well, it is a funny channel inhibitor. So we could see over here in the middle that during normal influx, sodium goes in, potassium goes out. Sodium is positively charged. It allows this increase in amplitude of positive charge ions inside the cell, and it leads to active depolarization. Over here, you see where the Ivabradine has blocked the funny channel, so the sodium cannot get in, and all it does is it slows the diastolic depolarization phase. Just by slowing that diastolic depolarization phase, it slows the whole cycle and thereby slows the heart rate. So the actual active depolarization doesn't change, repolarization doesn't change, the way the conduction gets down to the ventricle doesn't change, it doesn't change your ejection fraction, it doesn't change ventricular conduction or ventricular contraction, mechanical contraction. All it does is work right over here to slow diastolic depolarization. And by doing that, it slows your heart rate. So the hypothesis in the SHIFT study was that if we slow the heart rate, it's going to reduce the risk of cardiovascular outcomes and symptoms in patients with New York Heart Association functional class 2 through 4 heart failure, patients with systolic dysfunction, so HFrEF patients, that are in normal sinus rhythm, because remember, the effect only occurs inside the sinus node, and you got to have a heart rate greater than 70 beats per minute. And again, they wanted to make the hypothesis be in patients who are already on a beta blocker, because what do beta blockers do? They slow your heart rate, right? So we want to make sure patients are getting evidence-based therapy first. So the real hypothesis here was that heart rate is not just a marker, but we can modify heart rate, slow it down, and in some way help our patients. So that was the real theory behind getting this research done. So the next one. So this was the study design, and I just wanted you to see this briefly. We're not going to go into details. Patients were placed on 5 milligrams twice a day with meals of Ivabradine, and then it was 5 milligrams to start with, and then at 2 weeks or 14 days, they were assessed again, make sure their heart rate didn't get too low, make sure everything was okay. If all was good, they were increased to 7.5 milligrams, and then followed again at day 28, and then every 4 months after that. And then if the heart rate got too low, was between 60 and 50, they may have gone down from 5 milligrams down to 2.5 or just stayed at the 5 milligram dosage. And then this was an active study, and you could see there was a placebo arm that was studied at the same point in time, and patients were studied for 3.5 years. Again, another very large study. We don't have that many large studies out there in heart failure, so a very large study. Not too many people were lost to follow-up. The median time to follow up was 22.9 months, so almost 4 years. And these are more Kaplan-Meier curves like I showed you earlier. You could see months at the bottom. You could see the outcome going up across the top. This one is looking at cardiovascular death or heart failure hospitalization. And you could see there was an 18% risk reduction. The hazard ratio was 0.82. So an 18% risk reduction, and the number needed to treat for 1 year was 26. The authors then went and separated out cardiovascular death and hospitalization for heart failure. It turned out that all the benefit was really under hospitalization for heart failure. And you could see here there was a 26% risk reduction for hospitalization. So in your patients with reduced ejection fraction, heart rates greater than 70 beats per minute, that are symptomatic with an ejection fraction of less than 35%, you could really help maybe prevent or reduce rehospitalization, 26% relative risk reduction here. They also looked at death from heart failure, and that also achieved a 26% risk reduction. When they looked at the cumulative incidence of heart failure hospitalizations, first and repeated, there was also a 25% reduction. So this isn't just the first hospitalization, but over time, slowing the heart rate was very beneficial. And so now you could see over here, if you compared, remember that 87 and that almost 50%? Look what happened in the treatment arm. Now we could see people with a much lower risk of mortality compared to what we saw before they were the patients that were in the placebo arm. So you could really see the difference here when you look at this side and compare it to the placebo arm. Now, I just wanted to mention that this drug seemed to have other effects that you didn't hear about maybe in the original analyses, but again in sub-analyses were published. On the left side, you can see left ventricular end systolic volume index. This tells us how big our left ventricle is. And again, we usually like to say that if there's a 15% reduction in the size of the heart in terms of volume, that's a clinically significant difference. And so if you look over here, you could see the Ivabradine compared to the placebo, and that was statistically significantly better reduction. So that was very positive. This side over here is looking at ejection fraction. Many of you know that clinically, we like to say if your ejection fraction goes up by 5%, that's clinically significant. Of course, if it goes down by 5%, that's also clinically bad, right? And you could see over here, if we just look at the arm, the arm that's got the 5% difference, again, statistically significantly better on the Ivabradine side. So again, this drug reduces rehospitalization, may improve ejection fraction, and decrease the size of the left ventricle. So it was significantly greater improvement in heart failure-related quality of life as well when they studied that. It was meaningful to the Ivabradine. The placebo arm had no improvement in quality of life. And it was really interesting. The quality of life seemed to improve more as the magnitude of the heart rate reduction was greater. So people who had greater reduction had greater benefit. The mean heart rate reduction, by the way, with this drug is 10 beats per minute. And it's a greater reduction if you have a higher heart rate to begin with. So in conclusions, what we found from the HF study was that in patients who meet the criteria, again, heart failure and reduced ejection fraction, heart rate greater than 70 beats per minute, symptomatic functional class 2 to 3, stable patients in the outpatient setting who are already on a beta blocker or cannot tolerate a beta blocker, they are contraindications to a beta blocker, that this drug has the benefits you see right here and that we should add it to therapy. So what did the guideline recommendations say? They said, again, it was a class of recommendation 2A, which means that it was useful, we ought to do it, and it was a B, which means moderate evidence because of the one big study. R means randomized again. And what the recommendations are is that Ivabradine can be beneficial to reduce heart failure hospitalizations for patients who are symptomatic and meet all the criteria we just talked about, when they are already receiving guideline-recommended evidence-based management therapies, including a beta blocker at maximum tolerated dose, and you must be in normal sinus rhythm with a heart rate greater than 70 beats per minute. So those are the guidelines that came out, and I hope at least I've given you that overview now of why the recommendations are the way they are. For those of you that are interested, there's more recommendations coming. They wanted to get these published first. The other recommendations are just now being put forth, and they just 2 days ago sent a call for people who wanted to be reviewers. So the review process is just getting started, and there'll be more recommendations coming up within the next few months. So I'm very happy to answer any questions, and I understand it's the end of the day, and I'm between you and happy hour here. So feel free to not hang around if you don't have any questions and don't want to wait. Yes. Thank you. Yes. Yes, yes. Because there was 24% risk reduction in the lowest dose. But remember, in clinical, this is in patients who are on all the evidence-based therapies, getting everything correctly, and you don't know when they'd reduce the dose, right? We just know at some point they needed to reduce that dose. And so we should still use the drug the way it was given in the trial, which was at 200 milligrams a day in the trial. In real life, it'll be 97, 103 milligrams. So, yeah. And remember that over 60% of patients, or 60% of patients, around 60% of patients, were using that highest tolerated dose. So we really want to use the dose that was used in the trial. But if you need to down titrate, you shouldn't be afraid to do it. Just like what we say with carvedilol. We know that we see benefits at 6.25 milligrams, so if you could at least get them to that BID, you know you're going to see benefits. No, 6.25 was the cutoff for benefit. So 3.215, no benefit. Get them up to 6.25. Yeah, yeah. So that's the BID. So 12.5 a day, I guess you could say that would meet. Yeah, yeah. Yes. Yes. Yes, so that's a very good question. So the question was the 35% ejection fraction a design choice? When this study was started, they had already done some research in coronary artery disease and acute MI, and they were looking at patients with reduced ejection fraction, and that's when they started to see the signals that maybe heart failure would be the right target group. And so they started doing the research with low ejection fraction. The company, a lot of people have asked questions about preserved ejection fraction because we see a lot of heart rate problems in preserved ejection fraction, and maybe we could get the same benefit, but we don't have that evidence yet. The same is true for sacubitril valsartan. There is a study going on right now in patients with preserved ejection fraction, but you got to have a concise, controlled trial that's only looking at one arm, because then people will start making excuses. Well, they had too many people involved and they weren't similar enough, so they'll do that next. That's a great question. All I could tell you is that every single study, I heard this morning that Joanne Lindenfield didn't talk about preserved ejection fraction. There's about 15 studies that have all failed. And so we know it doesn't work, but we don't know what really does work. There is a couple trials right now. There's an exercise trial in preserved ejection fraction that we're waiting, anticipating the results on. Patients with preserved ejection fraction have totally different pathophysiology going on, so we can't assume that it's going to work. I don't want to make that assumption. We've got a study going on right now with sacubitril valsartan in preserved that is very promising in my mind, because there was a little study done a while ago showing that patients with preserved ejection fraction had an improvements in their BNP when they were placed on the drug. And so since their BNP improved, that tells me that we had some less ventricular stress, so maybe it will work in these patients. There's also been other drug studies out there that are in trials right now. There was also some hypertension type things, the vagus inhibition and all these de-innervation and all these other things, and nothing has worked with preserved. So right now there's not a lot to say, except you need to treat the comorbidities. And certainly there's enough comorbidities to go around. Atrial fib is one of our biggest ones. And again, we know what to do with atrial fib, and we know what to do with heart failure, but when you get patients with preserved ejection fraction and atrial fib, they're just miserable. So we really don't know how to get past this yet. So I guess in a roundabout way, I'm saying no, I won't know. I should have just said that, right? Other questions? Yes.
So if you have somebody on good doses of an ACE and their beta blocker,
Yes.
and you're ready to go to the next step, would you still do an MRA or would you go to an ARNI?
Oh, that's a really good question. So you've got to, so again, if you look at the cute little algorithm that was in the 2013 guidelines, they had ACE and beta blocker, and then they had add these other things. But remember, an ARNI goes up with the ACE and beta blocker. So it's even before you get to the diuretic, the aldosterone antagonist, or the hydralazine nitrate. So this is even above that level. So I would say that if you have a patient who's still symptomatic, even if you you may already have them on an MRA or a hydralazine nitrate, but you need to switch them to the ARNI at that time. And by the way, there were a few patients enrolled in the study that were in the ARNI group and also had hydralazine nitrate. Obviously, they didn't get an ACE inhibitor or an ARB, but they did have hydralazine nitrate and then had the ARNI added, and they were in there. I'm hoping that paper can come out telling us more about it down the road. So I would say it's actually above that level. So I would probably switch them first and then add the MRA or the hydralazine nitrate based on what's going on. So, yeah. Ah. Okay, so here's an interesting fact, and I didn't have time to talk about it today. When you look at the adverse event profile for Ivabradine, guess what one of the adverse events is? An increase in systolic blood pressure. So by lowering your heart rate, you actually help the heart pump a little bit better and the blood pressure goes up, and that's probably what's keeping the cardiac output up. So these patients actually do okay because their blood pressure goes up. And think of all the patients you've got running around with blood pressures around 100, 98, 92. And so Iva actually increased systolic blood pressure. So we did not see that as being a big problem. So good question. Yes? It's okay. Yes, very good question. So the question is, because you've got this extra BNP running around in your bloodstream, how do you test for biomarkers, right? Well, you can't use BNP as your biomarker because you're going to have an elevated level of BNP merely because you left more in the bloodstream now that you got them on sacubitril valsartan. So we always suggest using N-terminal proBNP because if you remember what happens inside the cardiac myocyte when the BNP is released, there's two things released. There's N-terminal BNP, which is an inactive compound, and then there's the hormone BNP. So you don't want to test the hormone BNP because we just raised it in the bloodstream. You want to test the inactive compound N-terminal proBNP, and that should go down. And it did go down in the national studies, the Paradigm Heart Failure. Any other questions? All right, well, thanks for hanging in there at the end of the day. I really appreciated that.